All right, welcome to your first lecture in Therapeutic Exercise 1. Today we're going to cover some of the foundational concepts for therapeutic exercise. So some of the roles, we're going to describe the role of the PTA in data collection and management of the orthopedic patient. We're going to list and describe components of physical function, identify types of normal, abnormal joint movements and activities, looking at the ICF model and seeing how it relates to participation and activities in daily life. Explain principles of muscular performance, including strength, power, and endurance. We're going to explain principles of resistance exercise and associated types of equipment used in resistance training. And we're going to discuss elements of balance and coordination. We're also going to look at musculoskeletal causes of and therapeutic exercise for gait deviations, review health records, document orthopedic interventions, and demonstrate actions and behaviors consistent with the PTA's value-based behaviors of the PTA. Okay, so first things first, we need to figure out what does therapeutic exercise really mean. So the definition here is a systematic, planned performance of physical movements, postures, or activities intended to provide a patient with the means to prevent impairments of body function and structure, improve, restore, or enhance activities and participation, prevent or reduce health-related risk factors, and optimize overall health, fitness, and the sense of well-being. So there's a lot of different reasons why we're going to utilize therapeutic exercise in the clinical settings. So some of the components of physical function, whenever we're writing programs for our patients and we're planning sessions, therapeutic exercise doesn't relate to just strength training. So all of these components are something that you're going to be planning and performing with your patients in just a few months. So let's look at the first component here of balance. So this is just the ability to align body segments against gravity to maintain or move the body within the available base of support without falling. So obviously we know balance is important. We have our static balance that we're going to discuss, and we have more dynamic balance. So balance is a big component of our therapeutic exercise. Then we have cardiopulmonary endurance, aerobic training, things like that. Really important for our patients with cardiac issues, pulmonary issues, and kind of everywhere in between. Coordination is something that I really harp our students to really focus on with our patients. What does coordination really mean? I think everybody has their idea of what that means, but in terms of physical therapy and the components of physical function, it's the correct timing and sequencing of muscle firing combined with the appropriate intensity of muscular contraction, leading to effective initiation, guiding, and grading of movement. So some of the things that I always think about, like if we're looking at balance, for example, a single leg balance, our patient has to coordinate a lot of different muscular contractions all at the same time. So our hip abductors, you're thinking glute med is going to help prevent hip drop, but we also need our quadriceps to fire and maintain a decent amount of tension throughout the quads. We need our plantar flexors and our dorsiflexors to maintain our balance as well, with some of that anterior posterior sway. So all of those muscles have to coordinate together. Really important for physical function. Then we also have flexibility and mobility. So we're going to be discussing a lot of stretching techniques, and that's one of the skill competencies for this course. So we'll be really familiar with that. We have muscle performance, strength, power, and endurance. We'll talk a lot more about those different types of strength training in a few chapters. We have neuromuscular control, which in my opinion sounds a lot like coordination and postural control, postural stability, equilibrium, and of course stability at joints. So all of these things we are going to learn about and learn the most appropriate application for these. Some of our therapeutic interventions can include, kind of like just building off that last slide, aerobic conditioning, range of motion exercises, muscle performance, strength, power, endurance, stretching, relaxation exercises, and even breathing and ventilatory muscle training. And then we also use these general scales of measurement to help us adapt our program, to plan our program for our patients. So you're going to be very familiar with reading an evaluation from a supervising PT. You'll see manual muscle testing, strength testing. You'll see the numbers for certain muscle groups. You may see dynamometry numbers. And based on that objective data, you're going to have to choose the most appropriate activity or exercise for that patient. You're going to have to choose the most appropriate position for that patient. Is it going to be with gravity eliminated, or is it going to be against gravity completely? So using these scales of measurement, particularly strength, is going to be very important. Also pain, using that analog scale, the visual analog scale, or the numerical analog scale, is something that's going to obviously affect your patient's ability to perform certain activities. So if they have a lot of pain with movements, maybe we need to address the pain first before we can start adding in strength training, or before we can start adding in range of motion. We're also going to be measuring limbs and things like that this semester. We're going to look at girth measurements with a tape measure, so we'll be really familiar with that. Again, if something is swollen, then we may think about elevation, compression, those kind of things. Vital signs, blood pressure, heart rate, respiratory rate, and O2 are going to be very important in determining if the patient is appropriate for therapeutic exercise. So we're going to look at all those ranges in a few chapters. There's definitely coordination tests that you're going to learn in your rehab class, and there's a nice little video link to that. So if you want to click on that, you can kind of see some of those different coordination tests. You'll probably be doing a little bit of a deep tendon reflex test in some of your courses. Not so much in my course in therapeutic exercise, but. And then the last one here, range of motion, standard goniometry. This is again going to really help you understand what's happening with the patient. If they have shoulder abduction movements that are only at 90 degrees, you kind of get an idea of what that patient starts to present like before you even see them in the clinic. And then you start thinking, is this going to be an issue of soft tissue mobility? Is it going to be an issue of muscle weakness? Like what's limiting their range of motion? So, and that's kind of the goal for all of these different tests. Like whenever we perform these tests or we're reading the results from these tests, it's just giving us an idea of what this patient needs from us as a therapist. What's going to be most beneficial for them. And don't worry so much about this figure 8 edema measurement. We will do that whenever we get to the chapter focusing on the ankle. But that's the image of the figure 8 ankle measurement technique. So we'll be doing that later on in the semester. Just to kind of piggyback off of my previous slides earlier, recording muscle strength, this is what it's going to look like whenever you start reading through some scenarios. You can see the joints or the motion at the shoulder, flexion, extension, internal and external rotation, affected versus unaffected. So you'll be able to really understand what some of these numbers mean in just a few weeks. Okay, these will make a lot more sense whenever we start our kinesiology lab. So just be prepared for that. But these numbers should tell you something right away, right? I'm already thinking for extension of the shoulder, 3 out of 5. In my head, I know what to do right away with that. And you will too, very soon. So here's some basic requirements of a movement system practitioner. So remember, as PTAs, we are the movement experts. We are supposed to know exactly what our patient needs to do to get better. We are supposed to know compensatory patterns and how to limit those, or if they really need compensatory patterns, following a stroke or something like that, we need to be able to identify, rationalize, adapt all of their movement patterns based on what they need. So how do we do that? Well, we need an in-depth integrative knowledge of movement systems and all of its component elements. We really need to be able to identify physical impairments across different systems. So is this a musculoskeletal issue? Is it a metabolic issue? Um, is it a neuromuscular issue? Is it, all of those things. So we need to be able to see our patient as they present in clinic, understand their impairments, and then understand why that is happening, or at least have some idea. Is there a little bit of guesswork involved in physical therapy? Definitely. There's not a prescription that fits every single patient regardless of their diagnosis. So, but the more you know about different systems and how to identify the impairments based off those systems, the better chance you have at actually treating your patient with effective interventions. And then again, we're going to really challenge you this semester to design an intervention program for patients to address their impairments. So lots of case studies and scenarios, and you're going to be using HEP to go. So if you look at your homework already, you probably see this in there. This is slow writing this, I apologize. HEP2go.com. Again, I think I mentioned this in semester 1, but this is a free account for you. So you can go sign up for it. You can create home exercise programs for your patients. You're going to be doing that a lot this semester, okay? So designing and applying. And of course, oops, as I wrote all the way over that, one of the things that we also need to consider as PTAs, as students in particular, you really need to maintain a safe environment for your patients. Okay, so let's talk about this ICF model, the International Classification of Functioning, Disability, and Health. So some of the main components of the ICF model would be body functions and structures, activities and participation, environmental factors, and personal factors. So all of these are going to contribute to how well your patient performs. We're thinking that's the prognosis, right? So we're going to talk about, oops, it's really hard to write with this mouse, I apologize. I need to get something better. But all of these are going to determine how well your patient performs in the long term. Okay, so all of those are going to have some kind of impact. So let's look at some examples. When we look at body function examples, right, this includes things like decreased muscle strength, limited joint mobility, spasticity, cognitive deficits. Body function, right? How is your body functioning? Well, it's not functioning as well because of this decreased strength that I have, or I have a hard time functioning because I have limited joint mobility. Then we get to the next component here, which is body structures. So we're thinking things like femur fractures. Something is actually wrong with the structure of the body, not just the function. But femur fractures, torn rotator cuff, disc herniations, amputation of a limb. Now these are all body structures, right, that would affect body function for sure. So if I have a torn rotator cuff, I'm going to have limited mobility. I'm going to have decreased muscle strength. So you can almost think of the body structure as the diagnosis. Okay. And then because of that diagnosis, what functional limitations are they experiencing? So you'll need to know these for any quiz questions. And then we look at activities and participation examples. So I always like to think of activities as, a lot of these end in ing, reaching, grasping, lifting, carrying, throwing, squatting, ascending, descending stairs. It's the activity itself is going to limit the participation. So if I have a hard time reaching, let's say above my head, I'm going to have a really difficult time with self-care, like combing my hair, putting on a shirt, those kind of things. If I have a hard time lifting or carrying objects, that might limit my ability to work as a construction worker. If I have a hard time ascending or descending stairs, that may really make it difficult to ambulate in the community if there aren't elevators, escalators, those types of things. But the participation you can think of as these kind of recreational leisure activities. The activities restrictions are really those kind of, at least the way that I want you to think about it for now, are all of these movements that end in ing: lifting, grasping, carrying, throwing. So again, you're going to need to know those as well. And then we have the environmental and personal factors. So environmental factors include things like family or caregivers, accessible public transportation, adaptive equipment, workplace accommodations, you name it. Personal factors: age, gender identity, coping styles, motivation, cultural background, lifestyle choices, and past experiences. So all of these together, if you're thinking of all of the components: body function, body structure, activities, participation restrictions and limitations, environmental factors, and personal factors, again, are all going to give us an idea of how this patient is going to perform in the long term. What's their prognosis? Is it good based off all of those components? Or are there some things that are really going to limit their ability to participate in physical therapy and ultimately participate in those leisurely activities that we talked about, getting back to work? Okay, so in order to really manage our patients well, we have to do a few things. And in your first clinical rotation, you're going to be expected to do some of these things. So these first couple ones here: coordination, communication, a little bit of documentation. You'll probably get some introduction to that in this first rotation. But you're going to be expected to communicate professionally, competently with your supervising PT, any of the other PTAs you're working with, any other staff, and of course your patients. And you're going to have to coordinate with all of those people as well in order to really make the best decision for your patients. By no means are you going to be expected to go out there in your first clinical rotation and be a star at, oops, I don't know where that came from, at clinical decision making, right? A lot of you haven't had any experience in the clinic yet. So your clinical decision making, well, it's probably not going to be so good when you first start out, and that's okay. The goal is that by your third and final rotation, you are at entry level for clinical decision making. So that would include a patient presenting differently than normal, and you make a sound decision on what's the most appropriate thing to do next. And part of the way that we really get to entry level in clinical decision making is utilizing evidence-based practice. Okay, so there's a ton of different resources for you to check out online. And something that I would recommend is becoming a member of the APTA as a student. You get a very good discount, and it carries on for a few years post-graduation. It kind of tapers off until I think about 5 years, and then you're finally paying the full fee for the APTA each year. But if you're a member of the APTA, you get access to these clinical practice guidelines. And those are super important. Those are our professional organization's way of saying, here's the best evidence. This is what our PTs and our PTAs should be doing based off the most relevant research. So they give you examples of the types of research, the quality of the research, and then they give you some recommendations on what you should be doing with those patients based on their diagnosis. There's a few other different databases out there. So Central, Pedro, PubMed, those are all good, but you just need to make sure that you understand some of the biases that may be associated with these journals, with these studies. So you really need to look for a meta-analysis, randomized controlled trials, peer-reviewed stuff in order to make the best decision, with the highest quality evidence. All right, so let's start talking about strategies for effective exercise and task-specific instructions. This is where we start to get into the fun stuff. So as far as exercise, prescription, and progressions go, a few things that you need to consider. So determining specific goals is going to be performed during the initial evaluation with the supervising PT and your patients. So your patients are going to set some goals for themselves, and your PTs are also going to make some goals, short-term, long-term, that you're going to have to work towards. So we need to know what their goals are. And then we need to select interventions and maybe progress them or regress them to get to their specific goals. Okay? And then as soon as we select some interventions, we have a plan moving forward, there's a few other things that we need to consider for this initial exercise prescription, and that would be the load and the tolerance of your patients. So if you could imagine, right, you haven't worked out in years and years and years, you're probably not going to have a very high tolerance to exercise, right? You're probably not going to be able to load those tissues very effectively without at least causing some kind of harm or risk of injury. So we need to talk about some of those things that may affect exercise prescription and progression. Okay, so let's think about this for a second. So there's a few things that we need to look at. And I think one of the first things that is most important for you to look at is the tissue healing time frame, or the ability for the tissue to withstand any type of external load. Okay. Some of the other things that you need to consider, remember we talked about all of those different systems, is is there any type of comorbidities associated with this patient? Are all the systems functioning properly? Is the cardiac system healthy? Is the pulmonary system healthy? Is the neurological system healthy? All of those things are going to really affect how well your patient tolerates an initial exercise program. Okay? So let's talk about some of these modifiers that influence exercise prescription. So a lot of things that we just talked about. Tissue characteristics. So what's the time frame? What's the healing phase for this tissue? Is there significant range of motion deficits? Or is there tissue laxity? Those things all matter. What's the patient's exercise capacity? If they have, cardiopulmonary issues, you're thinking that you're not going to overload them with aerobic activities or anaerobic activities that would stress that system too much too quickly. Maybe eventually we can build up to something that's a little bit more challenging, but you need to understand the capacity that they have at that current time. Patient characteristics also matter a lot. Patients who are extremely motivated to get back, but understand the risks associated with moving too quickly, is kind of like the perfect balance for our patients as far as motivation levels. You'll see all the different types, right? You'll see somebody who's unmotivated and doesn't want to move because they envision or see movement as something that causes pain, right? They don't understand that it's going to take some time to get back up and moving. Yes, there's going to be some discomfort, but overall, in the long term, the movement's better for you. And then you'll have the patients that are too motivated, that are going to go above and beyond what their physician tells them to do, what we tell them to do. They're going to be, kind of borderline, breaking protocol, doing those things that are putting them at risk. So you need to understand that about your patients. That'll really affect maybe the home exercise programs that you give them, or the type of education that you give them. All of those factor into the exercise progression. And we're going to talk a little bit more about this in a few slides, but variables to use to progress and regress exercise load. So we talked about load and not being, thinking about the tissue characteristics and those types of things before you start addressing or applying load to those tissues. So some of the things that you can do to progress or regress loads on tissues would be just the volume overall. So this includes frequency, I'm just going to write this, intensity, type, and time. So frequency, intensity, type, time. So all of that is going to add up into volume. You can also think of this as sets, reps. So if I did 3 sets of 10, I have 30 total reps. That's volume, right? Plus 4 other exercises that I did the same set and rep number range for. Excuse me. All fits into the volume, kind of falls under that volume range. So how much are you doing every single day? Okay, how frequently are you doing it? How intense is it? What type of exercise is it? All those kind of fit into this volume piece or this dosage piece. Then we have to think about the exercise mode. So what type of resistance are we using? Are we using therabands where the more that you stretch the TheraBand, the more resistance you get? So kind of like an increasing resistance throughout the range of motion. Or are we using something like dumbbells, which stays constant? Are we using cable machines, which has, pretty free range of motion? Are we using machines that have a fixed range of motion? All of those things matter. Same with the stretch type. What speed are we performing this exercise at? If I have an athlete who's trying to return to soccer or anything like that, I'm going to have to increase the speed at which we're performing those exercises. If I have somebody who does not play sports and is just trying to recover from a total hip replacement, I probably don't need to increase the speed of those exercises much. At least that's beyond their functional capacity, right? We want to make everything functional for our patients. So the speed is something that we'll talk about whenever we look at specificity of training. What kind of contraction are we using? Are we using concentric movements? Are we using eccentric movements? Are we using isometrics? What are we doing? Are we using an isokinetic machine that has a controlled velocity? So we need to consider those, and we'll talk about, when is it most appropriate to use isometrics, when is it most appropriate to use concentric movements, and when is it most appropriate to use eccentric movements. So we're going to talk about that in the following chapters, but it definitely has a part in this exercise progression. External loads. What kind of external load are we using? Kind of like when we go back to this, what type of resistance are we using? And then also patient position is super important. So if, let's say, I have a muscle grade, I'm going to bring this back up, 2 out of 5. And let's say that is for the biceps, the elbow flexors, right? Elbow flexors. So what a 2 out of 5 means is that the patient can't complete full range of motion against gravity. So if I'm just standing and I'm doing elbow flexion, I would at least have to have a 3 out of 5 in order to perform that motion against gravity. So anything under that, 2 out of 5, I can't complete full range of motion. So I'd have to change the position for the patient if we're going to focus on strength training. So maybe I have to eliminate gravity for this person that has a muscle grade of 2 out of 5 for the elbow flexors, and then we can work on strengthening that muscle. So patient position is super important, also due to muscle fiber alignment and orientation. So we're going to talk about all those things as we get into the lab setting, but patient position, very, very important. And then, of course, I have some suggestions for, practical, effective exercise instruction. So we're going to talk about these different types of motor tasks. We're going to talk about phases of learning, cognitive, associative, autonomous. For somebody who is just learning an exercise and they haven't done anything quite like this in a while, you really want to select a non-distracting environment for that exercise instruction, especially if the patient is very distractible and you work in a busy clinic and all those things. So you want to select something that's an environment that's non-distracting for them so that they can really focus on the activity that you're showing them. Initially, you want to teach exercises that replicate movement patterns that are simple, but relatable to functional tasks. So you're going to educate them here as well. I'm going to teach you this shoulder flexion exercise where you're lying supine and you're letting gravity kind of assist you in deflection. Some of your patients may wonder, why you're doing this. It seems really simple and easy. But maybe we're just trying to get some range of motion stretching so that once they master this skill and this activity, they can move on to a standing shoulder flexion that's going to help them reach into their cabinets, which was one of their long-term goals. So you want to make sure to teach them exercises that are going to replicate movement patterns that are functional, and tell them why you're doing it, right? Make sure you educate them on that. And something that I am just a big stickler about is that, I believe all PTs, PTAs, anybody who works in physical therapy or something similar to it should be able to demonstrate proper performance of an exercise and then ask their patient to give them a return demo. It kills me when I see PTAs, PTs, just hand a patient a list of 10 exercises and they're like, I'll be back in 5 minutes. And then the patient has no idea what they're doing because there was never a demonstration, there was no patient education given. So this is something that you as students in this course are going to be really challenged with. If you're not super comfortable or confident with your exercise, knowledge or demonstration abilities, well, you're going to get a lot of practice in this course, but you absolutely need to demonstrate those exercises for your patients. Okay, so let's look at some of these concepts of motor learning. And we're going to talk about practice here too. So concepts of motor learning, we're going to look at these different types of motor tasks, which we're going to see on one of the next slides. And we're going to look at progression of these motor tasks and these different stages of motor learning. All these factor into, the type of intervention that you're going to be performing with your patients. So let's look at these different types of motor tasks first. So the first one that we have here is what we call a discrete task. So the definition is that there's a recognizable beginning and an end, and typically these discrete tasks isolate a specific muscle group. So contracting a specific muscle group. So let's think of, again, let's just use something simple like elbow flexion. If I'm doing a biceps curl, there's a beginning and an end of the movement. I begin with my elbow extended, and then I concentrically contract, and that's the end of that movement. And then I return to the starting point. And I'm only isolating the elbow flexors. So the biceps brachii, the brachialis, the brachioradialis, like some of those big muscle groups. But it's isolating. Okay, so a very discrete task, beginning and an end. Then we move on to the serial task, and it is exactly what it sounds like. It's a series of discrete movements combined in a sequence. So eating with a fork is our example, okay? So we have a lot of different movements that are required to, pick something up with a fork and then finish off by eating it, okay? So we need to have the dexterity and the fine motor skills to grasp our fork, first of all, okay? So we have that kind of abduction of the thumb or adduction of the thumb, okay? Kind of like a add to side type grip. So we could just break that down and do a discrete task over and over again, right? But now we're combining a lot of these different movements. So we have that abduction of the thumb to grasp our fork, and then we have some wrist flexion, maybe with some radial deviation, and then we have elbow flexion to bring it up to our mouth. So all of those we could break down into discrete tasks, but we're just combining them here to perform something functional. Okay, so a series of discrete tasks. And then a continuous task is the easy one here. Repetitive, uninterrupted movements that have no distinct beginning and an end, like cycling and walking. Okay, so let's look at these stages of motor learning now. So we've talked about the different types of tasks: discrete, serial, continuous. Now let's look at these different stages that your patients are going to go through when learning activities and exercises. So let's look at this cognitive phase first. Okay, cognitive means the patient doesn't know what to do yet, right? They're just trying to figure out, what do I do for this exercise? How do I do this exercise? And they're just trying to get the feel for an exercise. They're by no means masters at this activity yet. So a lot of our patients are going to start off here in this cognitive stage, and that's okay. And that's when we really need that non-distracting environment. Then we move to the associative stage. So in this phase, or this stage here, our patients they know what to do now, they know how to do it, they got the feel for the exercise, but they're still just fine-tuning. So there's going to be some errors, but not as frequent as you would see with the cognitive stage, but they're fine-tuning here. And then we get into the autonomous stage here. So movements are automatic. Maybe your patients can do multiple tasks simultaneously as well. So I have, a couple different images over here. So I have this one up top on the right side. You can just see this dude is hammering that golf ball. Maybe he's not making the best contact, but it's automatic, right? You can see the ball fly. He doesn't have to think about what he's doing. He is in that autonomous stage. Then we have, on this bottom image here, Charles Barkley, great basketball player, not so good at golf. Look at that. So maybe that's just his swing, but in my opinion, he is still in this cognitive phase of learning. He knows what to do. He's trying to figure out how to do it. He's trying to get a feel for his golf swing. Okay, I don't even think he's in this associative stage yet. He's not fine-tuning. He's trying to figure out something that's going to work for him. So those are just two examples of what you might see. Okay, so let's look at progressing these motor tasks. So we're going to use a taxonomy of motor skills and learning to kind of help us with progressions and regressions. So some of the main things that we're going to talk about on this next slide include the environment in which the task is being performed. Is it being performed in an open environment where there's a lot of distractions? Or maybe the surface is moving? Or is it performed in a closed environment where there are minimal distractions? They're on flat ground. There's nothing that's moving in their immediate environment. So that's going to make a big difference. Is there any inter-trial variability with the activity? So is the activity changing at all during each rep? Is it random? Or is it just kind of like blocked? Is it really repetitive? So the variability of an exercise is going to really affect somebody's ability to learn as well, but it's an easy way to progress something. Third one here, is the patient's body remaining stationary, or are they moving during the task? So if you don't think that is going to affect how difficult an exercise is, then you probably haven't done much exercise. And the last one here, presence or absence of manipulation of an object during the task. So if you're having your patient squat, are they having to also manipulate an object at the same time? I would really only recommend that once they get to at least the associative stage, but really the autonomous stage. So that all builds onto this slide here, which is the taxonomy of motor tasks. So you can see this is something that we performed in lab already. We have our body stable, we have our body transport, we have without manipulation of an object and with, okay? We have without variability, with variability, and then we have a closed and an open environment. So the easiest out of all of these tasks is right here at this top left corner, okay? As we work our way down through, we get to this bottom right corner, which would be the hardest. So let me back up for a second. So this top left corner, Our body is stable. Okay? We are not manipulating an object. There's no intertrial variability, and we're in a closed environment. So for somebody who's truly in the cognitive phase of learning, this is where you would probably want to start. Okay? As we move down this direction, you're thinking that your patient is getting into at least the associative and then the autonomous phase by this slide here. So this one at the very bottom is our hardest. And let's look at why. So our body is in transport. We are manipulating an object. We have intertrial variability, and we're in an open environment. So that's going to be very difficult. So an example here, shopping in the supermarket, walking a precious pet on a leash. Okay, so important to know and understand the differences of all of these different variables, because this is how you can progress exercise without just adding weights, without just adding sets and reps. There's a lot more that we can do, right? We can change the environment the patient's in. We can add variability. We can have their body moving at certain times. So all of those things we can utilize to better progress our patients. So now let's talk about these different types of practice, and then we're almost done with this. So yes, we are talking about practice, okay? And it's super important. So some of the things that we're going to discuss on this next slide are part and whole practice, practice order, so blocked, random, blocked. And then we'll maybe touch on the physical versus mental practice a little bit. But I really want you to focus on this slide, okay? So really important. So part practice. Let's talk about part practice and whole practice first. So I'm going to start with whole. So whole practice is the entire task that is performed from beginning to end. So let's think of this as a squat. Okay? Squat. The whole thing, beginning to end. You sit up from a chair, you sit back down to a chair. That's the whole task. Now, let's go up to part practice. So let's say our patient is really struggling with a sit to stand or just a squat in general. How do we break it down into separate dimensions with the most difficult parts first? So let's just say that our patient is having a really hard time pushing their hips posterior to get a hip hinge, okay? And that's what's really limiting their ability to squat with proper technique and without pain in their knees. So if that was the case, then I would take that squat and I would break it down first into the most difficult part for this patient, which is the hip hinge. So I would demonstrate what the hip hinge looks like and tell them, give them verbal cues, give them visual cues with the mirror in front of them. So we need to push our hips posterior and maintain an erect spine as we push our hips posterior. And I would practice that over and over again until they felt comfortable with the hip hinge. And then once they did, then I would add a second part. All right, so once we get to the hip hinge position, now we're going to bend our knees. Okay, and we're going to lower ourselves slowly. So that's an example of something like part practice, and that's a very basic example. They may be more complex than that if you have patients that you're dealing with who've had stroke or have had TBIs or something a little bit more difficult. But regardless, it's the same. We're going to break it down into smaller tasks. Okay, so now let's talk about blocked order, and random blocked order. So let's look at blocked order first. This is a task or a series of tasks performed repeatedly under the same conditions. So once my patient learns how to squat properly, I'm going to go to this blocked order practice here, okay? I'm going to have them perform that squat repeatedly under the same conditions so that they are able to master the squat. So maybe I'm having them do sit to stands from a very specific height chair, and I have them do 3 sets of 10 or 3 sets of 20, whatever it is, okay? I'm not changing anything. I'm just trying to repeat that under the same conditions so that they master the skill. Let's say they've done that and they've mastered the skill now. Maybe in a few sessions, I'm going to move to something that's a random order, okay? So variations of the same task. So we're still squatting, but there's different variations here now, okay? In an unpredictable order. So maybe I have a metronome. And if you don't know what a metronome is, it's basically an auditory tool that kind of sets a pace. So if you set it at 60 beats per second, you may hear, that's going to keep a pace for you, okay? So it'll beat 60 times in 1 minute. If I said 60 beats in 1 minute. So maybe I'm going to set that metronome at 60 beats. That'd be a lot of squats. Let's do 30 beats, okay, per minute. And every time it ticks is when you have to extend your hips and return to the starting position. So let's say they've done 5 squats, and then I change the metronome on them to be faster, right? So they have to match the metronome. So every time it ticks, they have to stand up, extend their hips, return to the starting position. So it moves from 30 beats per minute to 45. They do 5 squats, and then I put it all the way down to 2 beats per minute, okay? That's really slow. But I'm changing the speed at which they are performing this exercise is the point that I'm trying to make. So it's a variation of the same task. We're still squatting, but it's random. They don't know what I'm going to change the metronome to, and it's different every 5 reps. They don't know what's going to happen. Okay, so variations of the same squat, but it's in an unpredictable order. And then I can move to random blocked order practice. So we're still doing variations of the same tasks in random order. Okay, the only difference here between random order and random blocked order is that it's kind of a combination. We're going to do each variation repeated. So let's say let's change it up a little bit. So let's say I want to shoot basketball, and I'm practicing my jump shot. Okay, random blocked order, variations of the same task. So I'm practicing my jump shots, mid-range, mid-range, mid-range. Okay, but I have somebody who is rebounding and throwing me the ball, and I don't know. Maybe I have a starting spot at the top of the key, and every time I shoot, I have to return to the top of the key. So every time I shoot, I run back to the top of the key. My rebounder is going to throw a ball to the left, the right side, and then I'm going to shoot it from there once I catch it. So no dribbles, nothing like that. I'm going to catch, and I'm going to shoot. So let's say my rebounder throws it to the right side at the top of the key. He's going to do that more than once. So I'm going to shoot it as I move to the right, return to the top of the key. He's going to take it over to the right side again. I'm going to shoot it, return to the top of the key. Maybe I'll do that 3 times. And then after that 3rd time, I return to the top of the key, and I don't know where the ball is going to go next time. So maybe he throws it to the left. Maybe he signals me to just go straight back. So, maybe take a drop step, something like that. But the point is that you don't know the next variation, but once you do know it, you're going to repeat it more than once. Okay? So random blocked order practice is a little bit of a combination of both the random and the blocked order, hence the name. And then, of course, we also are going to give our patients tons of feedback during their exercise. So there's different types of feedback. So you can think of it as knowledge of performance versus knowledge of results. Your patient is also going to get some of this intrinsic feedback from themselves. So proprioceptive, kinesthetic, tactile, visual, audio cues are going to be very helpful for your patients. If you think about that cognitive phase of learning again, right? Trying to get a feel for the exercise is what they said. The intrinsic feedback is sometimes very hard to own in on for your patients. And if, again, it's a new task for them, it's going to take them a while to really understand that type of intrinsic feedback. But if you've ever played sports before, or something along those lines, or you play video games, right? You know that you're in that autonomous phase when you don't have to even think about it, and you just know that it feels right. So if you go golfing and you're like, my swing feels good today, that's intrinsic feedback, right? You don't have to think about it much. You're just going out there and letting it rip, which is a great feeling. So that intrinsic feedback is really important, and I really encourage your patients, or I encourage you to educate your patients on the ability to feel certain exercises and when it's right and when it's wrong. You can also do augmented extrinsic feedback, sensory cues from an external source like a therapist, muscle tapping, those kind of things. Even some of the biofeedback machines for muscle contraction and the ability to perform relaxation techniques, like those kind of things can also be very helpful. And there's a few different ways that you can also schedule your feedback. You can do it concurrent, post-response feedback, immediate, delayed. Uh, you're not going to need to know anything really about this slide other than you should be giving your patients feedback, and it's going to take some time to really feel confident in giving them feedback on the spot. But the more you practice here, the easier to be once you get to the clinic. And I really encourage you just to check that box there, box 1.22 in your textbook. It talks about the characteristics of learners in the cognitive phase, the associative phase, and that autonomous phase. So just go check that out. It may help you in your homework assignments. And I believe that's it. So please feel free to reach out to me with any questions. If you have any questions about the homework or anything that's bothering you about the lecture or the lab. I hope you enjoyed this first introduction to therapeutic exercise 1, and thank you for dropping by.